come to the stage? And John, could you bring a chair?
Is Hannah with us? Hannah, welcome. Please unmute yourself.
Hello.
Hi, Hannah. Again, for those folks online, you can type your questions in. We've got all the speakers up here on the stage. And kick off, Charlotte.
So are there any questions from the audience before we take any more? Go for it.
This is a question to Kevin. With all the dose adjustments we have used when we use belantamab on a compassionate basis, we found it similar. Are you going to reproduce the results you've seen in the trial? Number one. Number two, use of this anti-BCMA inhibitor, will there be an implication for later on response to a bispecific or a CAR-T?
So for the first question, I think you asked, will you get the same response and duration of response if you dose reduce? We don't know the answer to that. I mean, as I say, that the evidence potentially is that in the trial, the patients that got at least 3 months off treatment were still having the same outcome. So I think you could potentially predict that would be the case. But in truth, you'll need data from things like the PROMISE study to completely confirm that. I think the answer is probably yes, but I don't know. And I didn't quite get the second question, so...
Would there be an implication for subsequent future treatment with the bispecific or CAR-T you use?
Yes, there is. So there's data from, well, with CAR-Ts at least, there's data from CARTITUDE-2 study, which specifically had a few patients who had had previous BCMA treatment. That did include both antibody-drug conjugates and T-cell engagers, and there was a significantly reduced response rate with cilta-cel. So where you normally expect essentially 100% response rate, it was down at about 50%, and that did include the antibody-drug conjugates. Now, I don't think I've seen necessarily the same strong data for the T-cell engagers, but they're reduced as well. So it does have an impact. I mean, it can still work, but there is more likely to be resistance, yes, for probably all the data that we saw this morning with Palineri's example.
Hi, this is a question for John. Hello. Thanks for a lovely talk, everyone. I was very impressed by the fact that you said that in your elderly, quite extensive cohort, you didn't have any ICANS or CRS. Is that correct? And if that's the case, did you use anything prophylactically? And if not, do you think it's because of the age or a selection of patients?
Yeah, no, that's a good question. I mean, we haven't really seen a great deal of CRS or ICANS at all. As I say, probably about 35–40% of grade 1 only. We've only used tocilizumab a couple of times. Most of the temperature has just settled down, and no one's ever needed, fluid support or oxygen. And in terms of the ICANS, I was on call earlier this week, and we've started another lady who's 86, and she dropped her ICE score to 7. So there probably has been one now, grade 1 ICANS, hot off the press. But yeah, we didn't give her any steroid either. Within a few hours, she was sort of back to normal. So yeah, no, I don't know whether it's because we'll see how well the drugs work in these older patients. If the T cells are a bit older and a bit more tired, then maybe that's a reason why. But time will tell, won't it?
Can I just introduce Marketa Camilleri from Cambridge, who run a virtual ward system for bispecific antibodies. So if we could pass the microphone. There are many hospitals in the country who have the virtual ward system. We heard from Francis about the outpatient delivery of bispecifics. So Marketa, a few words about your virtual ward system.
Thanks so much, Kartik. So it was mainly inspired by Leeds. So Leeds pioneered the way. But Cambridge had a couple of unique issues. So we don't really have an ambi unit, and physical infrastructure was a problem. And we have a very good relationship with our regional district general hospitals who are not transplant centers. So if I present to them a pathway that works in a transplant setting, they will say, but we are not transplant centers. So I decided to get creative. We have a very good relationship with our virtual ward team who do a lot of work with medics, and they also take care of our patients who have neutropenic sepsis but are stable, and they give ambulatory tazocin. So I approached our virtual ward and I said, would you take care of these patients? And they instantly said yes. So what we do is we have strict eligibility criteria. and if they which are very similar to the Leeds criteria that have been mentioned today. And if they meet those criteria, they are introduced to virtual ward. They are provided with equipment, which we went for 24-hour monitoring, actually. So it's 24-hour temperature, 24-hour pulse and SpO2, and also a blood pressure monitor. And they get hooked up onto an app, and all of that data gets transferred across to our electronic health record. So we are quite lucky. We've got Epic, and all of the data, we can observe that in real time. Patients do get alerts if their OBS are off, and they are encouraged to phone us, but generally we are the ones that call them to check on them, saying, are you okay? We also use just-in-case decks. The big advantage is, there are some disadvantages, obviously, in that you need the infrastructure, but I guess the one advantage is we were able to set up the service on what is currently already existing in the NHS. I think hematology aren't really big adopters of virtual ward, but the NHS virtual ward services are increasingly looking for innovative ways to use that service, and we have been quite successful at implementing this pathway, and it does work, it is safe, and other hospitals are considering it. Please do reach out to your virtual ward teams, and if you need help setting this up, please don't hesitate to get back in touch, especially if your colleagues need a bit of encouragement.
Thank you, Markita. What do you shall?
Thanks, Kartik, and thanks, everybody.
Go for it.
A basic practical question in regard for bispecifics. Usually what we see is the patient after the first loading dose, after the first dose of bispecific, it's usually within 48 hours, they have a rise in their white cells, and then they have the first spike of temperature. So usually, obviously, blood cultures, and we start broad spectrum antibiotics because of the first spike of temperature, although not requiring oxygen or any other marker. So it would be grade 1 CRS. But then if they do continue to spike, maybe within 6 hours, we do give them tocilizumab if they have the second spike. So what do we suggest? Should we give them a dexamethasone dose at that point in time, or we wait for more than 24 hours fever spike and then, because this is what we do, obviously we all worried of CRS and ICANS and everything. So this is what probably the first reflex is. Yes, if the second spike, all right, proceed with tocilizumab. Or should we give them dex at that time point and then see?
Can I roll that question to Hannah, if you're able to hear us okay online?
Yes, no, I think it's difficult. Certainly as a CAR T centre, we're very liberal with the TOCI because it's there and we can use it. But I think you often don't need to go in with, you're right, just a fever. You don't need to go straight in with something. You can sit and watch and consider something if it's been there for more than 24 hours or not. We would normally use tocilizumab first and only very rarely have to use dexamethasone for just a fever.
I would agree. We're very liberal with the TOSI, and it helps you to get to the next dose without delay. So it gets your patient either out of your hospital or off your ambulatory care list faster. So yeah, I had a question just kind of, I guess, also sort of on the same line, but for Francis, I guess, around how to choose who's suitable for outpatient, and then I guess coming into that, are you considering debulking patients before starting bispecifics in any cases?
So might answer those in reverse. So I think debulking is a really important area, and we're a little bit, certainly in our trust, a bit restricted in what pharmacy will let us get away with using to do that. So we do, particularly for patients that have got really rapidly progressive disease or bulky plasmacytomas, I usually debulk, but I can only use methylpred to do it. And if I'm debulking somebody, they're going to be in because by definition they're high risk and I'm worried about them. I would like to be able to debulk with something that might be a little bit less lymphotoxic, but that's what I've got available, so that's what I use. In terms of who goes ambulatory and who goes as an inpatient, it's those criteria that I described about disease and about comorbidities and about whether I trust the patient, and a little bit of gut feeling, to be honest. You know your patients, you know, you've kind of worked with them often through several lines of treatment, and I know who I I think is safe and I know who isn't. And there's definitely an element of just clinical judgment going on there.
Great, thank you. Question?
Another question for Francis. So in your ambulatory patients who call up having had a temperature at home and who've taken their dexamethasone, if they subsequently attend and are well, CRS grade has gone back to 0, have they bought themselves an admission at that point, or do you monitor them for a period on your day unit? How does it work then?
So we're getting more and more relaxed about that, but nearly every temperature happens out of hours. And out of hours, our admissions unit is run by SHOs with a registrar on call from home. So on the whole, those patients get kept until the following morning, are seen on the post-take ward round, get given their next dose of ELRA, and then go home. So we don't quite save an admission, but for our ambulatory patients, the median length of stay is 1 day. For our inpatients, median length of stay is 9 days. So it is a massive bed saving.
Jonathan?
So this, I guess it's for all the panel, but just for centres who are setting up bigger centres such as UCLH, we've used TEC and LRAN, but would you have any advice to smaller centres with pharmacy capacity, how they might pick between those two agents in terms of efficacy and convenience, and whether it's necessary to have both available on your site?
Yeah, I mean, it's a really good question because, you know, I don't think there's much data to distinguish between the two of them. In Eastbourne, we've mainly used elranatamab. We have used teclistamab and talquetamab, and obviously, as I was saying, you know, we'll have trials opening using those drugs. The reason we've used elranatamab more is because when the compassionate access scheme was open, it sort of then followed into being NICE approved. But we do aim to start using some tech as well, just because if for any reason there's a shortage, or you know, something happened, then you know, it'd be good to have the availability of both. But I don't think it really matters as such at the moment. Not in my experience anyway, unless there's other reasons that become evident in the future. But at the moment, I think if you're able to use, smaller hospitals able to use at least one, then that's fine.
It's worth saying that elranatamab is fixed dosing, and pharmacies quite like that. And also, because it's a steeper ramp-up, you get all the CRS front-loaded, so you're allowed to discharge after 2 doses, which we normally would, so it will save inpatient time as well, although we use equal amounts of both.
And equally, at extremes of weight, it can be desirable to be using weight-based dosing, so sometimes teclistamab can be a useful thing to use. But as with John, we tend to favour elranatamab for those reasons that you've heard.
Thank you. We've had issues with our patients on bispecific therapy, even despite IVIG and prophylactic antibiotics several months in. Do you have any particular strategy or experience with dose intervals, spacing out dose intervals, or giving a treatment break? And obviously with a treatment break comes the risk of losing funding if they start to relapse. Thank you.
Hannah, do you want to take that question around dose intervals because of challenges?
So yes, we've certainly got into the habit in a lot of patients, particularly if they've had a very good response, in dropping down to fortnightly elranatamab quite quickly rather than staying on the weekly doses. Similar with teclistamab, a lot of the trial regimens that I have open or have had open over the years drop very quickly down to monthly dosing, so we've even done that as well. So yes, we would reduce the frequency quite quickly in patients who've responded well.
That's exactly what, particularly the older patients, we try and give the first cycle as it should be, and then alternate week for cycle 2, and then quickly try and drop down to once a month if we can, in order to sort of balance out that infection risk and other side effect risk with response. But it all depends on the individual patient, their response and their history, I guess.
And Pfizer very quietly updated their SPC to include that monthly schedule now, so it is worth looking at that, and we do the same. We very proactively dose reduce as early as we can.
Brilliant. I'm going to flip to an ADC question online here, and Kevin, if you could start, please. It's a question from Caroline. If you have altered the frequency of belantamab in the first 6 months combination, do you tend to adhere to the reduced frequency in the maintenance phase, or would you revert back to standard frequency if the eye symptoms are improved?
No, I think if you've reduced it due to ocular toxicity or another side effect, we would tend to stick with the same reduced frequency. Yeah, because if you escalate, you invariably. I mean, the data speaks for itself. If you do stick to a kind of 3-weekly dose and you're getting eye toxicity, which most patients do, you will continue to get the same eye toxicity if you're re-exposed at the same dose and same frequency. So you do have to dose reduce.
Francis? John?
Yeah, totally agree. Once you've done that reduction, you stick with it. We've got patients that are just on a single dose of belamaf every 6 months in stringent CR, so you really can maintain those responses.
Thank you.
There was another question online that was about admissions for bispecific antibody therapy patients. I think the question was to John, but I know that you explained that your patients are kept in the hospital, so they don't need to go via A&E. I think the challenge is anybody doing ambulatory system where patients end up in A&E, and therefore how do you manage to retrieve them, or do we actually believe that ambulatory systems need to be enabled by direct access to wards?
So I'm probably a little bit of an outlier when it comes to this, because I think that CRS is no different from neutropenic sepsis. It's a different mechanism, but the side effects, what patients experience, is similar. And actually, I've never lost a patient to CRS. I have lost patients to neutropenic sepsis. So risks-wise, I don't think there's that much difference. The difference is familiarity with what we're doing. And when I was a junior registrar and people were having AML induction, they stayed as an inpatient for their entire neutropenic period because of worries about neutropenic sepsis. Now they're managed as an outpatient, and most hospitals have a pathway for those patients to be admitted, whether that's via A&E, whether that's via acute medicine, or whether that's via haematology. Those pathways exist. We just need to run these CRS pathways in parallel to that. But you can't do that overnight. You have to build up to that. You have to be familiar within your own service with how you manage these patients before I think you can escalate that out. So I think it is perfectly possible in the longer term for us to move a lot of these patients to an outpatient pathway, but I don't think you can just do it overnight.
Perfect, thank you. I hope that answered the question for the person online. Are there any other questions in the room? If not, we should probably bring this to a close, bang on time, for the first time all day. But I'd like to thank all of the speakers from the session, and thank you for listening. We now have a coffee break, but please be back at 3:25 for an update on AL amyloid.
Francis, you okay? Well done.
Very good. Thanks very much.